Chapter 6, the first part of Chapter 6, I've divided Chapter 6 into two parts. This is the process of normal labor. So labor is the process by which the fetus, placenta, and the amniotic membranes are expelled from the uterus. The onset of labor occurs due to a combination of things. It's changes in the maternal hormones, the stretched uterus, and the interaction between the placenta and the fetal pituitary, hypothalamus, and adrenal glands that cause the onset of labor. Factors that influence the process of labor include maternal preparation, labor support, maternal positioning during labor and delivery, and procedures encountered by the mother during the labor process. So with maternal preparation, is the mom ready? Did she attend childbirth education classes? Is she truly prepared? Is labor support, does she have a support person? The maternal positioning during labor and delivery can make a big difference in the labor progression. And what we need to do is make the easiest pathway for the infant to come out. And then procedures encountered by the mother during the laboring process. These are things that we may need to do. All right, settings for childbirth. We've got hospitals, LDRs and postpartum rooms. LDR is a labor delivery recovery room, and PP is postpartum room. There are several advantages to these areas in the hospitals. One of which being you're with you have every resource that you need right there with you at a hospital. You have anesthesia, you have an OR if you need to go to the OR, you have medications, you have everything there that you need, and appropriate staff to handle it. With a freestanding birthing center, these are usually operated by the hospitals, and there are advantages and disadvantages to these as well. Advantages are things like it's a home-like setting, it's usually a little less expensive, but the disadvantages, one of the biggest disadvantages is the fact that you have a delayed emergency care response. So if there is an immediate need for an emergency response, it's going to be significantly delayed in a freestanding birthing center. Home deliveries, there are advantages and disadvantages. Advantages are that the parents have more control. It's a low-tech birth, no monitors or IVs or anything like that. But disadvantages is that for home births, you may have a lay midwife. That means that's a midwife that's not been educated as a midwife. She's not been to school to be a midwife. These are midwives who are midwives because their grandmother was a midwife and their great-grandmother was a midwife and their great-great-grandmother was a midwife. And those types of midwives. And again, there is a significant delay in emergency care if needed when you do a home delivery. All right, components of the birthing process. We have the 4 P's of labor: powers, passage, passenger, and psyche. The powers is the effectiveness of the contractions, passage is the pelvis, passenger is the fetus, and the psyche is the preparation for labor and delivery of the mother. And it can also be previous labor experience of the mother can affect the psyche. So powers, we're going to break this down. Powers, there is a primary force and a secondary force. So the primary force of labor comes from involuntary muscle contractions of the uterus. The secondary force is what? The secondary force is the abdominal muscle contractions from the mom pushing. So there is primary and secondary forces of labor to help. Labor contractions, they dilate and efface the cervix during the first stage of labor. So dilate means open and efface means thin the cervix. So they dilate and efface the cervix during the first stage of labor. Uterine contractions are composed of 3 phases. You have an increment, acme, and a decrement. So the increment is the building of the contraction. It is the longest phase where the contraction gains strength. And then you have the acme, which is the peak of the contraction. The contraction has reached its strongest point. And the decrement, which is the relaxation of the contraction. The contraction of the uterus eases and relaxes to the uterine resting baseline. So here we have our increment, our acme, and our decrement. All right, the beginning of the contraction, the end of the contraction, and then we have the resting period. So this leads us into, we're going to talk about that in a minute. Okay, sorry. Powers. Contractions start where? Well, they start at the top of the uterus, which is called the fundus, and spread throughout the uterus, pushing the fetus where? Downward, which in turn puts pressure on the cervix to thin. What was the word for thin? That would be efface, and to open, and that would be dilate. This is the uterus between contractions when it's in its relaxed state, and this is the uterus during contraction, and you can see the significant movement of the infant with just the uterine contractions, and then you have the secondary of the mom pushing. And at resting, notice that the fundal height here, is lower at a resting state than when the mom is in the contraction state. In the state of contraction, I mean, the uterus literally just balls up, pushes the baby up and everything, and so it's going to be higher during that state. All right, to document contractions, we have to use 3 descriptors. That's going to be frequency, duration, and intensity. So we're going to start with frequency. Frequency is how often the contraction occurs. We measure it by counting what? How do we know the frequency? Well, the frequency is measured by counting from the beginning of one contraction to the beginning of the next contraction, and it is recorded in minutes. And then you have the duration, which is the time frame from the beginning of the contraction to the end of that same contraction. And that wording is very specific to ensure that you understand it's not the end of the next contraction, it's not, it's the end of that same contraction. It's how long the contractions last, and it's measured and recorded in seconds. And then we have intensity, which is the strength of the contraction. It's determined by palpating the fundus at the peak of the contraction, so at the acme of the contraction. It's documented as mild, moderate, or strong. And to palpate, because this is done by palpation, mild would be if you touch your finger to the tip of your nose, that would be a mild contraction. If you put your finger on your chin, that's going to be a moderate contraction. It's still kind of soft and squishy, but it's a little firm. And then if you put your finger on your forehead, it's nice and firm. That's a strong contraction. So that's how you're going to document intensity, mild, moderate, or strong, when you're documenting via palpation. And that gives you a good way to know if it's mild, moderate, or strong. Tip of your nose is mild, chin is moderate, forehead is strong. Can also be measured accurately by using an intrauterine pressure catheter, an IUPC, that is used when you do internal fetal monitoring. But primarily, we measure it with our, it's not, these are the ways you can accurately measure, is just palpation and the IUPC. All right, then you have that period of relaxation, the interval of resting between contractions. So during contractions, there's decreased blood flow through the uterine arteries and the intervillous spaces. Therefore, there's a decreased oxygen flow to the fetus. So with contractions, you have decreased blood flow to the baby, decreased oxygen to the baby. So it's very important for the well-being of the mom and the baby for this period of rest in the contraction cycle. It allows for the vessels to fill with oxygen-rich blood for the uterus and placenta, and facilitates rest so that the maternal muscles do not become overly fatigued, because they may be at this for a couple of hours. All right, second one we had was the passage. So the passage is the pelvis. The bony pelvis forms the rigid passageway in which the fetus is delivered vaginally. The shape and dimensions of the woman's pelvis indicate whether or not she will be able to have a vaginal birth. What two areas are parts of the passageway that are made up of soft tissue? Well, that would be the cervix is soft tissue, and the vaginal canal is soft tissue. So those are parts of the passageway that are soft tissue. Now you got a pelvic inlet and a pelvic outlet. So the pelvic inlet is if you are looking down at your own pelvis, and this is your AP diameters. AP is anterior posterior, so this is anterior. This is your symphysis pubis. This is posterior. This is your coccyx. And then you have your transverse, which is side to side. And these are your ischial spines in your pelvis. So that's how your pelvic inlet is measured. And then you have pelvic outlet, which is basically looking from the ground up into your pelvis. Okay. The mid pelvis is where you have the prominence of the ischial spines here in the mid pelvis. So it is the shape of the pelvic inlet that determines the pelvic type, and we have 4 types of pelvis. We have a gynecoid, anthropoid, android, and platypoid. The gynecoid is optimal for a vaginal birth. An anthropoid is elongated, the android is heart-shaped, and the platypoid is flat. I always think of platypus when I see platypoid, and they have that flat tail and bill. So gynecoid, this is the typical female pelvis shape. 1/2 of all women have a gynecoid pelvis. It's a rounded shape that allows for the infant to negotiate the dimensions of the bony pelvis. See, nice and shaped, just like the infant's head. Anthropoid, we said, was elongated, so this is much, very elongated pelvis, and that's can still be delivered vaginally, but it's a little more difficult. This android is the typical male-shaped pelvis, and see how it's this classic heart-shaped. It's kind of, it's long here and wide, and then comes in significantly. Very difficult to deliver vaginally. And then the platypoid, this is the least common type of pelvis, and it is a very flat pelvis. This AP diameter, very flat, not very large, very difficult to deliver. All right, the third thing we talked about was the passenger. So the passenger refers to the fetus, and with that, we have to break that down into 5 subcategories, and that's the fetal skull, fetal attitude, fetal presentation, fetal position, and fetal station. You're going to have to know these. I recommend making a chart. There's a chart hanging up in the classroom, and hang it up somewhere in your house so that you can see this frequently and it can absorb. You can memorize it, but you're going to forget it. I'm just saying. Most students do. All right. All of these things, the fetal skull, attitude, presentation, position, and station, they all affect the labor progress. So let's start with fetal skull. The most important fetal structure in relation to labor and birth, the diameter of the skull must be small enough to allow the head to travel through the bony pelvis. The cartilage between the bones of the fetal skull allow for overlapping during labor, which allows for a reduction in the size of the fetal head. So the bones, the skull of the fetus is not fused. The bones are not fused together so that those bones can overlap each other and allow for passageway through the pelvis. Right? Molding or elongating of the fetal head also allows for accommodation through the birth canal. And this molding or the elongation of the head is more pronounced in primates. If you don't remember primates, go back to one of those early lectures when we talked about definitions. All right, so here's the sutures in the fetal skull. These are the suture lines. So you see that the skull is not fused at all, and that is so that these bones can cross over each other as needed to shape the baby's head to fit through the birth canal. What you see here is your anterior fontanelle, which is diamond shaped, and your posterior fontanelle, which is triangular shaped. All right, then we've got fetal attitude, the most common and more favorable for vaginal birth. Fetal attitude is the position of the fetal head, basically. So the most common and favorable for vaginal birth is flexion. Flexion presents the smallest diameter of the fetal skull to the bony pelvis, which is approximately 9.5 centimeters presenting size, which is perfect to fit through our 10 centimeter dilation because fully dilated is 10 centimeters. Right, changes in the fetal attitude, particularly extension of the head, cause the fetus to present a larger diameter of the fetal head to the maternal pelvis, that ratio, making vaginal birth more difficult and sometimes impossible. So what we have here is a flexed position. This is what we want, baby's chin to chest, which presents right here. This measuring right here is approximately 9.5 centimeters from the forehead across the back of the occiput to fit through the birth canal. This right here is what we call military presentation. It is not flexed or extended. It is just looking straight on. But this, now we've come down quite a bit down here to above the eyes in measuring in the forehead to the occiput. And this measurement is quite larger at about 11 centimeters. And then we have this presentation. This is a brow presentation. Or, well, this one's a brow presentation. And this now is measuring the diameter that's coming through at the chin to the top of the head. Okay, huge, huge diameter. 13.5 centimeter diameter. Huge. Okay, and then we're going to have a full extension or a facial presentation, and that is when the baby has the head fully extended. And now we're measuring from under the chin to the top of the head around the anterior fontanelle. And this diameter presents at about 9.5, which is what we have in our flexed attitude. But these babies, you have a lot of facial presentation babies that are born this way, but they will have significant facial bruising from delivery like this. It's more traumatic. All right, then we have fetal presentation. This is determined by the body part of the pelvis that is lowest in the maternal pelvis. What is the presenting part? 3 main ways the fetus can present itself. This one is head first. It's about 96% of babies present this way. This is called cephalic. This one is feet or buttocks first. About 3% of babies present this way. This is called breech. And this one is transverse or shoulder presentation, which occurs in about 1% of births, where they will, transverse means across, they land across the uterus. So here's your vertex presentation or cephalic presentation. All right, this is what we want to have. And then we've got a breech presentation, and we can have variations of a breech presentation. We can have a complete breech like this, where the feet are up, and they're always kind of crossed like this, and just, you know, the buttocks presenting. An incomplete breech is where we have 1 foot down, 1 foot up, and a frank breech is where both feet are up. And these poor little babies, these frank breech babies, when they come out, it is so hard to diaper them and swaddle them, because these legs just flop right back up. That was the position they were in utero, and they flop right back up there. It's kind of funny, but anyway, so there are these definite differences. If you have this incomplete breech, as you can see here, we may be delivering, if we end up vaginally delivering, we may be delivering a foot first, and probably they're going to reach up in there and grab the other foot, deliver both feet, and then deliver the rest of the baby. All right, this is a shoulder or transverse presentation. So transverse, this is the transverse lie side to side like this. And shoulder, the shoulder really is the presenting part, whatever's lowest in the pelvis, and it would really be the shoulder as the presenting part. Then we have fetal position. This is determined by comparing the relationship of the presenting part, so the fetal presentation, to the quadrants of the maternal pelvis. So this is kind of confusing to some students, so be sure you've read over this and let me know if you have questions. Okay, so the nurse first has to establish the presenting part, so we have to go back to fetal presentation. What is the presenting part? And then the appropriate reference point. So if the fetus is vertex or cephalic, that's the same thing. The fetal position is referenced by the position of the occipital aspect of the fetal head. So what is the occiput? Well, the occiput is in the back of the head, where if you feel your head, you kind of can feel from your neck up, and then you feel where it sticks out and kind of, I don't know, I call it like a little shelf right there. That's the occiput. Right, so now we have to determine the side of the maternal pelvis that the presenting part is facing. So, for example, if the occipital, so if the back of the baby's head is facing the mom's right side, you always do it in relation to the mom's left and right, not your left and right. The back of the baby's head is facing the mom's right side, or if the occiput, the back of the baby's head, is facing the mom's left side. Right. Then lastly, we're going to determine fetal position. The nurse designates whether the occiput is facing the anterior or the posterior portion of the pelvis, or if it's transverse. For example, if the fetus is facing the mom's back, then he or she is in an anterior position because the occiput, which is the back of the head, is in the anterior pelvis. Okay? So we said the baby is facing mom's back. So the face is to the back and the baby's vertex, head down, faces to the back. That means the occiput, which is the back of the baby's head, is facing the front or the anterior of mom's pelvis. If the fetus is facing the mom's front, so that means the face is in the front, the occiput is in the back, then the baby is said to be in the posterior position because the occiput is in the posterior pelvis. Right? If the fetus is facing one side or the other, the left or the right, he or she is in occiput right or occiput left transverse position, depending on which way he or she is facing. So this gets confusing. You guys got to be sure that you're understanding this or asking questions if you're not getting this. This is looking in the pelvic inlet. Okay, if we had the pelvis here, pelvic inlet, this baby is in the occiput, the back of the baby's head is in the posterior because what I see is the front of the baby's head, which would be in the anterior pelvis because you have to imagine that there's a mom standing here. If I was able to draw, I could draw a little stick figure mom smiling out at you so you could see she was facing you. So this occiput is in the posterior position. If this baby's turned just slightly, and this baby is now LOP, that's left occiput posterior, because this baby is to the occiput, the back of the baby's head, is to the mom's left, but still posteriorly. This one is left occiput transverse because this baby, the occiput, the back of the baby's head, remember mom is standing here and she's looking at you, so this is her left side, left occiput transverse, sideways on the side. Now this baby is turning to where the front is turning towards the mom's back, and this is left occiput anterior. So this occiput is on the mom's left side, but it's facing more anteriorly. This is occiput anterior, straight up and down, not facing left or right, but the occiput is the anterior, the front of the pelvis. The back of the baby's head is the front of the pelvis. So basically what I'm saying is this is the back of the baby's head, this is mom's pelvis. So it's always the occiput, and then whether it's anterior, posterior, transverse, that's the second part of this. So this baby, this is looking again, here's the pelvis, and this is mom's pelvis, anterior pelvis, posterior pelvis, left occiput posterior position. Okay. I don't know, you've got to be sure you grasp that and you're understanding that. Now, the most common positions, fetal positions, are LOA and ROA. So left occiput anterior and right occiput anterior, left occiput anterior, right occiput anterior. These are the most common fetal positions. Now, if the baby is delivered what they call OP, that would be occiput posterior, right? The baby is OP, occiput posterior. That means that the back of the baby's head is to mom's back and spine, right? OP. That's called, the baby's going to be born face up. That's called sunny side up. And this position causes lots and lots of back pain and back labor for mom. Okay. It's pretty uncomfortable. All right, the fetus, this is posterior position. The fetus is facing outward towards the mom's abdomen. The occiput, which is the hardest part of the baby's head, is pushing against mom's lower back and sacrum, causing lots of back pain for the mom, which is referred to as back labor. Labor is often prolonged due to the different diameter of the head fitting through the maternal pelvis. And the baby may be born with bruising on their forehead, where the softer part of the head has been pushed against mom's bony pelvis, okay, because there's just that her bones and the baby's bones aren't going to move. So that's why usually if they're born OA, which you prefer, LOA or ROA, that means that their face, which is more squishy, is coming on the mom's bones and causes less pain. All right, this is still just trying to make sure you're understanding normal position and presentation. This is facing backward, so the baby is, this baby would be right occiput anterior, right? This baby would be facing forward. This would be not quite OP, not fully sunny side up, but this baby likely will be like that. If it's delivered this way, it would be left occiput posterior position. All right, then we have fetal station. This is the relationship of the presenting part to the ischial spines of the pelvis, which we talked about like the very first thing. So when the widest diameter of the presenting part is at the ischial spine, it is referred to station as zero station. Any position above the level of the ischial spine is a negative station because we're further away from delivery. Any position below the level of the ischial spine is a positive station. We're getting closer to delivery. +4 to +5 station means the baby is crowning and delivery is imminent and the fetal head is seen there at the vaginal opening. So fetal station, these are the ischial spines right here sticking out, okay? This is just giving you a reference that this is zero station at the level of the ischial spine. So right here, this baby is up here at -3, right? -3 station. This is not measure. I mean, we don't have these measurements obviously written down in the pelvis or anything. You do this based on palpation, and you have to get really good practice at it to get it down. All right, so it takes a lot of practice to get this right, but what you're doing is when you're palpating, when you're feeling for the ischial spines, and then you're moving up till you feel the baby's head, and I don't know, it's kind of like a guessing game, but you get trained at it and to be able to say if it's -1, -2, -3, or +1, +2, +3 station. Okay, these little notches are like the rugae in the vaginal opening, which helps that with that determination a little bit as well. So this is just a different type of picture showing you again the pelvis, the ischial spines here, and this being zero station, +1, +2, +3, and -1, -2, -3, and +1, +2, +3. Okay. The psyche. This is the psychological state of the laboring woman. The labor process can be enhanced or delayed. So it can be enhanced if the woman feels confident in her abilities to cope with the process of labor, and if the woman finds ways to work through the contractions. And it's delayed if the woman is fearful and tense, if the woman fights against the pain and the contractions. Excuse me. So I remember when I was in labor with my daughter, I can distinctly remember one of the nurses, or maybe it was even the physician, saying, if you would just stop fighting against this and push, you could have this baby. And, you know, I didn't realize that's what I was doing, but I was kind of fighting against the pain. Like I didn't have an epidural or anything with her. And so I was kind of fighting against that pain. All right. Normal childbirth. Events that occur prior to the onset of labor are events such as lightning, nesting, and Braxton Hicks contractions. So with lightning, this is when the presenting part settles into the maternal pelvis. This occurs approximately 2 weeks prior to the onset of labor. The woman has a sense that the baby is dropped. The mom usually breathes harder or easier. When she's going to breathe easier, she eats more or less at mealtime, or she's going to be able to eat more now. And she's going to have more or less pressure on the bladder. Well, she's also going to have more pressure on the bladder, so she's going to the bathroom a lot more. She may experience leg cramps and edema of the lower extremities related to the increased pressure in the blood vessels by the growing uterus. Then we have nesting. This is the burst of energy experienced by the mom to prepare the home for the new baby. She will do lots of deep cleaning, preparing meals, preparing the nursery. This usually occurs 1 to 2 days prior to the onset of labor, or even a week or so before labor. The cause of this is unknown, but one thing you want to educate is to warn the mom to be sure she's conserving enough energy for the actual work of labor. Okay, I think my husband probably wished this happened to me. I never had nesting. I never got this burst of energy, but I know a lot of women who have gotten that burst of energy. They've prepared meals for when they go into the hospital. They've prepared the nursery. I mean, they just have everything ready and clean, and it must be nice. And then we've got Braxton Hicks contractions. These are irregular, painless practice contractions. They're also referred to as false labor contractions. Do they or do they not increase in intensity, duration, and or frequency? Well, the fact is they do not. Okay, they don't increase in intensity, they don't increase in duration, and they don't increase in frequency. And that's one way to differentiate the contractions. I just thought that was a cute video describing Braxton Hicks contractions. All right, how are we going to determine true versus false labor? Well, this is true labor, this is false labor. So in true labor, we're going to have this progressive dilation and effacement. In false labor, the cervix does not change. In true labor, we have rupture of membranes. In false labor, the membranes remain intact. True labor, we're going to have a bloody show. False labor, no bloody show. In true labor, we'll have regular contraction pattern that becomes longer, stronger, and closer together. And in false labor, we have irregular contraction pattern. In true labor, the pain intensifies and radiates to the back and thighs. In false labor, the pain is uncomfortable, but it may not intensify, and it's usually confined to the abdomen. In true labor, the contractions continue to get stronger, even with position and activity changes. And with false labor, activity or position changes can decrease the frequency or stop the contractions. All right, with the mucus plug, it's a protective plug of mucus inside the cervix during pregnancy. And you, prior to the onset of labor, you will lose your mucus plug. That's going to occur 4 weeks to 1 day prior to the onset of labor. It expels as the cervix starts to open. When you lose your mucus plug, it's also known as bloody show. It is thick mucus mixed with pink or dark red blood. And it can be significant, I mean, not a huge amount, but it can just be a little bit at a time. You may lose your mucus plug over several days or at one time. Clinical signs that we would see or that are going to happen prior to the onset of labor, we're going to have cervical ripening, cervical effacement, and cervical dilation. And they have to occur in, well, effacement and dilation can occur together, but you have to have ripened cervix first before effacement or dilation can occur. So ripening is the softening of the cervix. And that softening has to happen so that we can have effacement, which is the thinning, and dilation, which is the opening of the cervix. All right, with effacement, the thinning or shortening of the cervix, it is recorded as a percentage. The normal cervix is approximately 2 centimeters long or non-effaced at 0%. So 0% effaced is 2 centimeters in length. and the cervix is completely effaced. It's as thin as a piece of paper, or what they would call 100% effaced. So here's before labor at your 2 centimeters. So you measure from here to here. That's what you're measuring. And in early effacement, see how much shorter this is, and thinner. See how thick this was? This one is now short. And now we have complete effacement, and we're getting a little bit of dilation here in the opening of the cervix, but we've got very thin effacement, thin cervix, and then we have complete dilation. So this now, here's the edges of the cervix here, and our cervix is now dilated 10 centimeters. All right, so dilation, the cervix opening is opening to allow the passage of the fetus. It is measured in centimeters. Complete dilation is 10 centimeters. In a primipara, they usually will experience effacement before dilation. In a multipara, effacement and dilation can occur at the same time, and multips will often dilate 1 to 2 centimeters before the onset of labor even occurs. Rupture of membranes. So we've got, we can have spontaneous rupture of membranes or artificial rupture of membranes. So with spontaneous rupture of membranes, we call this SROM, spontaneous rupture of membranes. If the contractions and cervical change do not occur with the onset of rupture of membranes, labor will be induced. Why? Well, we're going to then induce labor to decrease because of the risk for infection for the mom and the baby. If we don't have those membranes around the baby to keep the baby protected, and the mom and the uterine cavity protected, then we now have this open passageway for bacteria. So if contractions and cervical change don't occur with the onset of rupture of membranes with your water breaks, labor will be induced. It can be a trickle or a gush of fluid, depending on if it is a high or a low leak where the membranes rupture. Now, when the membranes are ruptured, you need to do an assessment. You need to assess the ruptured membranes. And you're assessing an acronym that they use is COAT or TACO, C-O-A-T or T-A-C-O. Doesn't matter the order. But C is for color. You need to assess the color of the ruptured membranes. The O is for odor. You need to assess the odor. A is for amount. You need to assess the amount of fluid. And T is for time. What time did the water break? So color, what color would we expect the amniotic fluid to be? Well, we anticipate it's going to be clear. It should be clear, right? Odor, it should be odorless for the most part. Amount, it really depends. It can be a significant amount or a little amount. And the time, it's very important that we know the time of the rupture of membranes. And I think we'll talk about that here in a little bit, but we need to know the time because we are not going to wait very long from the onset or from the time that the membranes rupture to the time that we deliver the infant, because the longer we wait, the more increased risk we are for infection for the mom and the baby. All right, we may do an artificial rupture of membranes or an AROM. The practitioner uses something called an amni hook, which is this right here, to put a small hole in the amniotic sac to stimulate the maternal hormones and to augment labor. Okay, and the procedure itself is called an amniotomy. So doing an artificial rupture of membrane, this is called an amniotomy. All right, mechanisms of labor, mechanisms of spontaneous vaginal delivery. In order for the vaginal birth to occur, the infant must pass through the birth canal or the passageway. So these turns and movements are referred to as the cardinal movements of delivery. And there are 7 cardinal movements that you're going to have to know. So, and understand what is happening during these movements. And I have a couple of videos posted to Blackboard. I can't encourage you enough to watch the videos. Read more about this in your book for sure. I mean, I'm going to tell this to you, but you're going to have to be able to grasp it. You can try to memorize it, but I'm just going to tell you it'd be so much easier if you understand what the baby is doing and learn it that way. All right, so the cardinal movements of delivery, the first is engagement. So we talked about engaging the baby's head or buttocks, whatever the presenting part is, hopefully the head, engaged in the pelvis. It's kind of stuck down in the pelvis. That's engagement. And descent means the baby's descended. It's coming down into the pelvic inlet. So a lot of people will actually put engagement and descent together as one step, and that's fine. Then we got flexion, internal rotation, extension, external rotation, and expulsion. And these mechanisms may overlap or they can occur simultaneously. But what is happening, so with engagement and descent, it's the initial movement of the fetal head into the pelvic inlet, like I was just saying. Flexion is the fetal attitude, presenting the smallest part of the fetal head to the dimensions of the maternal pelvis, and the fetal attitude that we want is flexion, when the fetal head is tucked to the chest, chin to chest. As the head descends during the labor, the fetus often assumes this flexed position because the head encounters resistance from the muscles of the pelvic floor, kind of forcing it into that flexed position. Now, internal rotation is the next step, and this is when the fetal head rotates from which position to which position. Well, the fetal head will rotate from a transverse position to an anterior position. So in early labor, the fetus's head presents to the maternal pelvis in a transverse position because the pelvis is widest from side to side. That transverse diameter is wider than the AP diameter. Then during active labor, the fetal head typically rotates to the anterior position, which is most favorable for delivery. So again, that's what we're saying. The occiput is in the maternal anterior pelvis. If the rotation does not occur, this labor will be prolonged because the widest diameter of the fetal head is presenting, making it a tougher fit. If the fetal head rotates posteriorly, so again, that's occiput posterior, OP, or sunny side up, instead of anterior, the labor may be prolonged as the infant has to rotate further to an anterior position prior to birth. The next step, or the next movement, is extension. This is when the fetus reaches the pubic arch. It extends the head. The head has to extend. It passes under the pubic arch and the symphysis pubis and then extends up. So that's extensions. And then we have external rotation. This is the birth of the head. And when you have the birth of the head, the shoulders must then line up with the head. And then we have expulsion. And this is the birth of the baby. It occurs after the delivery of both shoulders. Okay. This is breaking it down for you. Yeah, into a couple more. Well, I mean, this is showing you where the head's floating before engagement even occurs. Engagement, descent, engagement, flexion, descent. But you can read through there. And again, I've got several things posted on Blackboard. You got to know it. You got to know it. And you can memorize it, but it's going to be hard. It's a whole lot easier if you just can picture exactly what the baby is doing and how the baby is coming out. And put it in that order in your mind instead of memorizing it. I should be honest. All right. Stages of labor. Labor is categorized into 4 stages. So we have our first stage, which has 3 substages. That's early labor, active labor, and transition labor, or your latent phase, active phase, transition phase. So again, this first stage would be called the dilation and effacement stage. Your second stage is with the birth of the baby. The third stage is the delivery of the placenta. And the fourth stage is recovery. These are other things you're just going to have to know. You're going to have to understand this. We're going to break it down a little bit more. In the first stage of labor is dilation and effacement. That is the first stage of labor. And it begins, there's a beginning and an end, and to each of these stages, it begins with the onset of true labor contractions, and it ends with full dilation of 10 centimeters. The stage generally lasts 8 to 20 hours for primates and 5 to 14 hours for multips. Right? The first stage, again, is the first phase of the first stage, I guess, is the latent phase. Latent means not active, so this is your latent phase. In this phase, dilation occurs is about 1 to 4 centimeters dilation. The frequency of the contractions, you'll have a contraction about every 10 to 15 minutes. They could be closer together. Intensity, as the labor progresses, the contractions usually become stronger and closer together. In the active phase, remember, which is the second substage, we've got dilation of 4 to 7 centimeters. The frequency of contractions is every 2 to 5 minutes. The duration of those contractions is 45 to 60 seconds. And the intensity of the contractions is moderate to strong. Now, remember earlier we gave you these definitions for frequency, duration, and intensity. Be sure you understand how you measure frequency, how you measure duration, how you measure intensity. Right? Mom will have increasing discomfort. Primips usually dilate about 1.2 centimeters per hour and multips about 1.5 centimeters per hour. This is an average number, not set in stone by any means. And then we have the third substage, which is the transition phase. And here, this phase, dilation from 8 to 10 centimeters occurs. The frequency of the contractions is every 2 to 3 minutes. The duration is 60 to 90 seconds. The intensity is strong. This phase is characterized as the most difficult phase of labor. The woman has a strong urge to push as the fetus descends. Now, one other thing that's very important to remember about this, though, is that she may have this urge to push before the cervix is completely dilated. And so it is your job to make sure that you encourage her not to push, do breathing exercises to wait those extra contraction or two that it may take to get the cervix completely dilated. Because if she tries to push through that cervix that's not quite at 10 centimeters yet, it may be 9 centimeters or 9.5 centimeters, or what they call an anterior lip, where there's still just a smidge of cervix left in the that's not fully dilated. If you have that and she pushes through that, what happens is we get a slower labor progression, because now we cause a lot more swelling, and or we may get lacerations of the cervix, which can lead to hemorrhage. All right, the second stage of labor, this is when birth occurs. So again, there's a very definitive begin and end to this stage. It is characterized by maternal pushing, starts at 10 centimeters dilated, and ends with the birth of the infant. The woman feels as if she needs to have a bowel movement. So if the mom states to you that she needs to have a bowel movement anytime while she's laboring, can you let her get up and go to the bathroom? Can you give her a bedpan? Can you get her on the bedside commode? Really, what's going to determine what you can do is the fact that you must check her cervix first. Generally, she is not getting up to go to the bathroom, period. If you check her cervix and she's not fully dilated, let's say she's maybe 5 centimeters, you may give her a bedpan possibly, but she's not getting up to go to the bathroom. But the point being that she'll state she needs to get up and go have a bowel movement, and you've got to be vigilant about making sure that she does not get up and go to the bathroom, or she'll deliver this baby in the toilet. The average length of the second stage of labor for primips is 1 to 2 hours. For multips, is going to be a few pushes to an hour. Right? The fetus continues to descend and rotate, and pushing is characterized by steady, slow downward progression of the infant. And then we have the third stage of labor, which again has a definitive beginning and end. It begins with the delivery of the baby. It ends with the delivery of the placenta. This stage can last 35 to 30 minutes. We may get signs of placental. How do we know when the placenta is separating? Well, we may see a gush of blood. The umbilical cord will lengthen as the placenta is separating. That what we see outside of the vaginal canal, the length will lengthen, get longer, and we'll have a globular shape to the fundus as the placenta separates. Oxytocin is given via IV or IM possibly to help keep the uterus firm and control maternal blood loss. The fourth stage of labor is recovery. This begins after the delivery of the placenta, lasts about 1 to 4 hours. The woman is observed frequently for signs of hemorrhage or other complications. We're going to do vital signs, fundal checks. We're checking to make sure that the uterus is contracting and getting smaller. We're doing lochia checks to check the amount of vaginal bleeding. The woman is usually very tired and hungry in this phase of labor. The body is going through tremendous changes after the labor and delivery process. It's a lot of work. Right? The hard work of labor puts demand on the woman's coping mechanisms. So responses vary with different stages of labor. in the early stages of labor, in the latent phase, the mom's really talkative and excited. She may be anxious or apprehensive. Then we get into that active labor. She's going to be more introverted and using that energy to focus on the contractions. In the transition phase, most women have difficulty maintaining positive coping mechanisms during this phase of labor. They feel very out of control. This is when they need a lot of support and encouragement and positive reinforcement to continue pushing and, that they're doing a good job with this labor process. In the pushing, they get this sense of relief. They get better coping skills because they feel like they have more control over the situation now because they're doing something. They're able to do something now to help move the process along. If a woman is inadequately prepared for labor and loses control during labor, they will usually exhibit crying, screaming, and or thrashing behaviors. I've seen this many times. The response will slow the labor progression due to muscular tension because these tense muscles work against cervical dilation and fetal descent. And that's kind of just like what they were saying to me when I was delivering was, if you would stop pushing or working against the pain, basically, so tense about it, then I'm working against the cervical dilation that naturally the body is trying to do. Okay, so sometimes when they give an epidural, we'll talk about this later on, but sometimes giving an epidural or pain medication relief can really help with that process because then you're not so tense and you're not working against those natural processes of labor. All right, be sure that you review table 6.5. I'm pretty sure that's the right pages, 146 to 147 in your book for physiologic changes in labor. And that was a lot of content that we covered, lots and lots of really important material in that lecture. Be sure that you understand it, make charts, make graphs, whatever you need to help you grasp those concepts better, okay? And be sure that you let me know if you have any questions.